Well, hello from London again, and this is our final day of ESC 2024. Still, there are a lot of hotline trials, and one of them, Khaled, was the bioadaptor technology. Tell us a little bit about that one.
Yeah, it was quite interesting. The INFINITY-SWEDEHEART trial, which looked at the percutaneous coronary intervention with the Dynamax bioadaptor platform compared to contemporary drug-eluting stent platform in a large, broad clinical population. Well, the rationale, as you know, behind this study was that stent-related adverse events continue to accrue after the first year post-PCI at a non-plateauing rate of around 2 to 3% per year. And this happens with all platforms, whether it's BMS, first or second or third generation DOS. This phenomena may be attributed to things such as strut fractures, loss of vessel compliance and vasomotion, the limitation of adaptive remodeling of a vessel that is caged by a rigid metallic implant, as well as the development of latent neoatherosclerosis. The unique features of the Dynamax bioadaptor stent allows for uncaging of the vessel after the first 6 months and restoration of normal vessel compliance and vasomotion, and that this might mitigate against the disadvantages of fixed prosthesis. Hence, the study was designed to evaluate the safety and efficacy of the Dynamax bioadaptor technology compared to the Resolute Onyx stent in a large multicenter randomized clinical trial in a broad patient population representative of daily practice, including patients with acute coronary syndromes. The effect of the mechanism of action of reducing hemodynamic modulation in a pre-specified landmark analysis 6 months and therefore powered for superiority. In fact, this was an all-comer study. 76% of patients had acute coronary syndrome. 90% lesions were either B or C. One important thing is to be randomized, you have to have a successful pre-dilatation. Now, there were important exclusion criteria as well. Left mains lesions were excluded, as was ISR, CTO, osteal lesions, patients on dialysis, those with severe LV dysfunction were all exclusion criteria. In the end, 2,400 patients were randomized in a 1-to-1 ratio to either the Dynamax bioadaptor or the Resolute Onyx stent. The primary endpoint was target lesion failure, which included cardiovascular death, target vessel MI, and ischemia-driven TLR, definite or probable stent thrombosis, and non-inferiority at 3 months. The secondary endpoint is a landmark analysis of target lesion failure, target vessel MI, and cardiovascular death after the 6-month landmark analysis, towards the end of the study. Well, what were the results? INFINITY-SWEDEHEART, the largest randomized clinical trial of this technology, met its primary endpoint of non-inferiority to the Resolute Onyx platform in 12 months. The primary endpoint occurred in 2.35% of patients with the bioadapter technology versus 2.7% in the drug-eluting stent, meeting the non-inferiority clause of 12 months. Now, more importantly and more interesting is the pre-specified powered landmark analysis that occurs after you censor events. It occurs in the first 6 months, and look what happens after the first 6 months. And this demonstrates a plateauing of further events after the 6 months in the Dynamax population, with a significant reduction in target lesion failure with a p-value of 0.003 and target vessel failure after the first 6 months, again in favor of the biomatrix technology, and demonstrating that even though events continue to accrue with the conventional drug-eluting stent, they did plateau with the bioadapter. These results support the potential novel impact of this technology in coronary artery disease treatment or action through its unique mechanism. Now, interestingly, Dr. Capodanno did comment on this study, and in his commentary, he did note that the primary endpoint occurred less frequently than expected. In fact, the power calculation used for this study was based on an event rate of 7.5%, while the observed rate was actually only 2.8%. Hence, the study may have been underpowered. Yet he went on to state that these findings are confirmed at long term with other control arms. This technology could become really a serious contender to the current paradigm of drug-eluting stents. So it was really an interesting study.
It was, and to continue on with the imaging, intracoronary imaging theme, that's actually the ESC adopted since last year when a lot of the randomized trials were actually presented here. we come with the next trial, the OCCUPI randomized clinical trial. So this was OCT-guided PCI for complex coronary lesions, and the objective was to compare clinical benefit in OCT-guided versus angiography-guided PCI for complex lesions, and assessed the rate of major adverse cardiovascular events at 1 year. So the hypothesis here was obviously that OCT guidance for complex lesions would in fact reduce event rates. They enrolled about 1,604 patients who required drug-eluting stents for complex lesions, randomized 1-to-1, where 803 assigned to OCT and 801 assigned to the angio only. Follow-up was for 12 months, and they managed to achieve that in over 90% of the patients. And the primary endpoint was, of course, major adverse cardiovascular events, namely cardiac death, MI, stent thrombosis, and ischemia-driven target vessel revascularization. The median age was 64. Men were about 80% of this population. Acute coronary syndromes were 49%, and acute MI was actually 20% of those enrolled. The OCT group had greater use of high-pressure post-dilatation with a higher post-procedure MLD achieved. Both contrast use and procedure time was significantly longer in the OCT arm, but that actually did not translate into any worsening of nephropathy or contrast-induced acute kidney injury. The primary endpoint occurred in 4.6% of the OCT-guided group and in 7.4% of the angio-guided group, again with a relative risk reduction of about 38% here. Very consistent with all the previous trials that had been presented here last year, such as the October and so on. As for the secondary endpoint, there was also a significant reduction in ischemia-driven target vessel revascularization and spontaneous MI with OCT guidance. And the OCT guidance was able to achieve acceptable stent expansion in 73%, stent apposition in 81%, and absence of edge dissection in 99.6%. I think those are remarkable numbers. Compared with achieving optimization criteria and those not achieving optimization criteria, this did actually translate into a reduction in the primary endpoint from 8.6% to 2.9% with a p-value of 0.001. So OCT-guided PCI did in fact lead to a reduction in 1-year composite of cardiac death, MI, stent thrombosis, or target vessel revascularization compared with angio guidance. And I think this is just really a call for us to start adopting image guidance in general in our practice. But Khaled, there's more trials that were presented here, and one of them really revolved around drug-coated balloons. So do you want to tell us a little bit about the trial? This was done in de novo lesions, as opposed to, again, last year, a lot of the data that came out focused on in-stent stenosis.
Yeah, so lots of people are talking about drug-coated balloons in de novo lesions. The first study that actually has looked at this. So it was it's called the REC-CAGEFREE study, and it's compared the strategy of drug-coated balloons with rescue stenting if needed, compared to conventional upfront strategy of drug-eluting stents. So the hypothesis was, in non-complex PCI, irrespective of target vessel diameter, would this strategy of drug-coated balloon with rescue stenting, if needed, prove to be non-inferior to a primary upfront DES strategy? Now, including criteria, patients with both ACS or chronic coronary syndromes were included. They had to have de novo lesions in native coronary vessel, regardless of vessel diameter. And it had to be a non-complex PCI, and the defined non-complex PCI is a PCI that required no more than 2 target lesions or vessels that were planned to be treated with either DS or DCB, and not to have a treatment length within the treated vessels of greater than 60 millimeters. Now, patients with cardiogenic shock, in-stent restenosis, left main stenosis, complex bifurcation, CTOs, or calcified vessels requiring atherectomy were all excluded. 2,900 patients were randomized and equally divided between either the DCB strategy or a DES strategy. And as you remember, randomization only occurred after a successful pre-dilatation. Successful angioplasty was defined as a residual visual estimate stenosis less than 30%, with TIMI-3 flow and no high-grade dissections. The primary endpoint was a composite of 2 years of cardiac death, target vessel MI, clinically and physiologically driven TLR. And this was a non-inferiority analysis. Important to note here, in the DCB arm, 9.4% of patients who had a pre-dilatation ended up requiring bailout stenting. So this is a sort of a disclaimer here. At 2 years, the primary endpoint occurred at 3.4% in the drug-eluting stent arm and 6.4% in the drug-coated balloon arm. Looking at the individual components of the composite, cardiac death occurred in 1.2% of the drug-eluting stent, 3% in the drug-coated balloon with a p-value of 0.05. Target vessel MI, 1.6% drug-eluting stents versus 1.9% DCB, not significant. When we looked at TLR, that's clinically and physiologically driven TLR, significantly higher in the drug-coated balloon arm, 3.1% versus 1.2%. What is also interesting is when they looked at, when they stratified the results by vessel size, they found that these differences between the DCB strategy and the DES strategy was far greater or bigger when we're dealing with large vessels and more comparable when you're dealing with small vessels. So if the vessel was less than 3 millimeters, the event rate in the DES arm was 4.4 versus 5.1 in the DCB arm. If you're looking at larger vessels greater than 3 millimeters, the event rates were 2.5% in the DES arm versus 7.5% in the DEB. The conclusion was this: the study was powered, it did not meet its primary aim of non-inferiority, and a strategy of drug-coated balloons with rescue stenting failed to reach non-inferiority compared to upfront DES at 2 years. And DES implantation, at least for now, should remain to be the preferred treatment strategy for these patients.
Well, that's interesting in terms of drug-coated balloons and bioadaptor technologies, but we really can't close off ESC 2024 without touching on lipid management. There was quite a lot that was discussed, including during the chronic coronary syndrome guidelines when they were elaborated about cutoffs and so on. But an interesting trial presented today by Dr. Michael Gibson was the use of Apolipoprotein A1 infusion in cardiovascular outcomes in patients who have an acute myocardial infarction, the AEGIS-II trial. So given the well-established relationship between LDL and plaque burden and the greater risk reduction with PCSK9 inhibitors in patients with baseline elevated LDL, the efficacy of CSL112, that is the ApoA1 infusion, which impacts efflux, may be impacted by the baseline LDL cholesterol, and that was the hypothesis behind this whole trial. It was a huge trial. They enrolled over 18,200 patients with an acute myocardial infarction, be it STEMI or non-ST elevation MI. They were randomized within 5 days of the acute event to a 4-weekly infusion of the CSL112 or a placebo. The primary endpoint at 90 days with key secondary endpoints at 180 and 365 days were reported, and namely that was the time of the first occurrence of a cardiovascular death, myocardial infarction or stroke. In terms of the primary endpoint, it was noted in 5.2% of the placebo arm and 4.9% in the active treatment arm, which was not significant and remained so at 180 and 365 days. These results were consistent across all subtypes of MI, including type 1 and type 4. When analyzed according to the baseline LDL level at randomization, there was no difference in the primary endpoint in those with a baseline LDL that was less than 100 milligrams per deciliter. Now that cutoff was the standard cutoff that was chosen in the previous trials of the PCSK9 inhibitors and hence chosen here. But there was a significant reduction in the primary and secondary endpoints for those receiving active treatment with a baseline LDL that was higher than 100 milligrams per deciliter at randomization. The number needed to treat was 66 at 90 days, but then it was 50 at 6 months and 48 at 1 year. It would be interesting to see and capture the NNT, whether it continues to a trend continues to show a decrease over an extended period of time beyond 1 year. So the conclusion really here is that an infusion of ApoA1 is plausible in hyperlipidemic patients presenting with an acute myocardial infarction and a high LDL level. There's a trend for the individual components of cardiovascular death, MI, and possible plaque stabilization to improve with this infusion, but it remains hypothesis generating in spite of it being a very large trial. And just a little bit more on hyperlipidemia data came from the 4-year trial, which was reported today, noting that the benefit of LDL reduction using PCSK9 inhibitors across all BMI brackets was there, especially profound in those with a BMI of more than 35. And so it would be interesting today to conduct this kind of a trial and see and understand the effect size in the setting of the novel drugs that are now available, such as Ozempic and so on, for the treatment of obesity, which weren't standard of care at the time of enrollment of the PCSK9 trials several years ago. Thank you for staying tuned with us all 4 days, and see you next time.